Mary is actually doing kind of double, triple, quadruple duty, and so I'm going to step in and go ahead and give some opening welcome remarks and introduce Dr. Tamma before we start this morning's grand rounds. So quickly, a couple of reminders for everyone. Next week, next Friday, October 2nd, we're going to be having our quality improvement series as part of Pediatric Grand Rounds. Just as a reminder, this is a biannual presentation. We talk about events that were considered significant, had a root cause analysis, some other kind of review that resulted in an action plan. Should be really interesting with a panel discussion. And that's going to be followed up the following week with Dr. Mark Neve from UT Southwestern, who's going to be speaking as part of the 3rd Annual Diversity and Inclusion Forum. The next slide, for those of you who are interested in claiming CME credit for this morning's session, please don't forget to text code 36310 to 844-560-1904 to confirm your attendance. We are also going to include the code and the phone number in the chat box during the session. Super important announcement and reminder for everyone. Wanted to let everybody know that the new seminar series, COVID-19 in Children, will have its first session next Thursday, October 1st at noon. As a reminder, this is a seminar series that's co-directed by Dr. Roshni Matthew, as well as Alan Schroeder. Includes a really phenomenal planning committee, and it's designed to provide trustworthy and up-to-date information on pediatric COVID via weekly sessions on Thursdays from 12 to 1. Again, the first inaugural session is going to be next Thursday, October 1st. This first session is to kick off this series is going to be a conversation that will broadly touch on several different aspects of COVID-19 with 3 really titans in the field of pediatric infectious diseases. Really fortunate, really lucky to have Drs. Bonnie Maldonado, Phil Pizzo, and Charles Prober joining us next Thursday. So please do try to make every effort to attend, and there's more information on the website link there. Lastly, please don't forget that the 3rd Annual Diversity and Inclusion Forum, I think this will be on the next slide, there we go, hosted by the Leadership Education and Advancing Diversity, or LEAD program, is going to be on Friday, October 9th. With a kickoff with a Grand Rounds talk by Dr. Mark Neve from UT Southwestern. Registration is now open, and the QR code that you see in that upper right-hand corner can be scanned to visit the website. So that's all we've got by way of announcements this morning, and I'd like to go ahead and introduce our speaker, Dr. Pranita Tamma. So Dr. Tamma is currently an associate professor in the Department of Pediatrics, Division of Pediatric Infectious Diseases at Johns Hopkins University School of Medicine. After graduating from the combined undergraduate medical school training program at SUNY Downstate College of Medicine, she completed her residency in pediatrics and her fellowship in pediatric infectious diseases at Johns Hopkins, and also received a Master's of Health Science degree from the Johns Hopkins Bloomberg School of Public Health. Dr. Tamma currently attends on the PEDS ID service at Johns Hopkins and is the founder and current director of the Pediatric Antimicrobial Stewardship Program at Johns Hopkins. Where among many responsibilities, she's developed and currently helps to manage a number of institutional guidelines that are aimed at improving antimicrobial utilization, several of which might actually look very familiar to the people here at Packard, as we have borrowed them generously. Dr. Tamma's research focuses on developing novel methods for detecting multi-drug resistant gram-negative organisms. She's the author of multiple comparative effectiveness series and studies aimed at identifying the optimal treatment approach for infections due to these organisms. And she's currently funded via K23 grant to evaluate the use of MALDI-TOF, or matrix-assisted laser desorption ionization time of flight, to rapidly identify carbapenemase-producing Enterobacteriaceae. She's been the recipient of a lot of funding from a variety of sources, including the NIH, FDA, AHRQ, and CDC, and is the author of over 100 manuscripts, review articles, and book chapters. Most recently, Dr. Tamma was the lead author on the recently published IDSA guidance on the treatment of antimicrobial resistant gram-negative infections, which focuses on the management of ESBL, CREs, and difficult to treat multi-drug resistant Pseudomonas. She's the recipient of multiple awards, including a Pitts Young Investigator Award and a Society for Healthcare Epidemiology of America Pediatric Investigator Award. And I would say that among the members of the pediatric infectious disease community, she is nearly everyone's go-to person when there's a question related to the diagnosis and management of difficult to treat multi-drug resistant gram-negative infections. We're really lucky to have her here this morning to discuss the landscape of antibiotic resistance in the United States, and just really sorry that she couldn't be here in person to meet everybody. But with that, very excited to hear the presentation, and I'll go ahead and turn it over to you, Pranita.
Thank you so much, Hayden. That was very nice. And I too am very sad that I couldn't be there in person. But hopefully in the future, I'll get to meet many of you. Hopefully there won't be too much background noise. It feels like all my neighbors are mowing their lawns at the moment. But we'll try to do our best. So thank you all again. And as Hayden mentioned, I'll be focusing on the landscape of antibiotic resistance in the United States. I have no disclosures. And my objectives are to provide an overview of gram-negative resistance in the United States, to discuss the role of antibiotic stewardship programs in limiting antibiotic resistance, approaches to improving the diagnosis of gram-negative resistant pathogens, and approaches to treating gram-negative resistant infections. So I thought I'd start off with a clinical case. This was a patient I took care of when I was an infectious disease fellow. It's a 15-year-old male who was born in the United States, and he was recently diagnosed at that time with acute myelogenous leukemia. He was otherwise healthy. He used to travel to India every summer to visit his family. And about 3 weeks into his initial hospitalization, he developed respiratory distress and was found to have a multifocal pneumonia. It was recognized as a carbapenem-resistant Klebsiella pneumonia, which was recovered from bronchoalveolar lavage fluid. You could see here that it was resistant to most of the antibiotics we commonly use to treat infections. And on special testing, so phenotypic testing to look if this specific bacteria was producing a carbapenemase enzyme, it was found to be positive. There was also some additional testing, which I'll discuss the significance of later, to look at the presence of particular resistance genes. And this patient had something called an NDM, or a Nudeli metallo-beta-lactamase, and an OXA48 gene. And basically, these are different types of carbapenemase genes. And he also had something called a CTXM gene, which is a ESBL gene. And often these travel together on the same plasmid. So we basically had started him like we often do with children who have neutropenic fever on cefepime. And as more information came back, we had an organism growing, he was ill, we changed him to meropenem. A few days later, we had our susceptibility tests back and we broadened coverage even more. At that time, we didn't have access to some of the newer antibiotics we have now. But unfortunately, this child died. And, it is a very terrible situation because, perhaps if we had known earlier what his organism would be susceptible to antibiotic-wise, this may have potentially been prevented. So it really reminds us how we need to work harder to optimize our process for diagnosing drug-resistant infections so that we can ensure that critically ill patients are placed on appropriate therapy as soon as possible. So the CRE are one of what the CDC considers to be a significant antibiotic resistance threat. They note in a report in 2019 that there's more than 2.8 million antibiotic resistant infections per year in the United States, and more than 35,000 people die as a result of this. So how did we get here? Bacterial resistance is definitely not a new phenomenon. Multi-drug resistance has been found in bacteria that have been separated from human environments for millions of years. So as an example, this is La Chiguilla Cave in New Mexico. And some scientists went in there, they cultured some of the surfaces, and this area, even the waterways, has really been separated from any kind of human activity for several millions of years at least. And what they found, surprisingly, was that the bacteria they identified had resistance genes to antibiotics like meropenem, daptomycin, fosfomycin. So it just goes to show that antibiotic resistance is a natural phenomenon, but probably very similar to global warming. Certainly human activity has a major role in this. And it seems that with the use of antibiotics, and particularly the overuse, we really do accelerate this process. So I was going to focus on 3 areas where I do either hospital-based work or research that I think all contribute to drug resistance. one being antibiotic stewardship, one related to improving diagnostics, one related to novel therapeutics. Infection control, I think, is equally important in terms of making sure people are washing their hands, practicing contact precautions as needed, and cleaning the environment. But I won't be addressing that today. So just to sort of step back a little about antibiotic stewardship, this is Ann Miller. When she was around 31, she had a severe group A strep infection, sepsis. And she was hospitalized. There's reports that her temperature went as high as 107 degrees. And she was actually the first patient who received penicillin. And amazingly, she survived the infection. She went on to graduate from Columbia and had a very long, productive life. And this is a picture of her with Alexander Fleming. And this and countless stories, particularly when antibiotics first became available, really underscores how important antibiotics are. They've saved countless lives. And as I mentioned for the child I presented earlier, certainly prompt administration of appropriate antibiotics is really critical whenever a patient needs them. But we also know that about half of all hospitalized patients who receive antibiotics, and about 30 to 50% of the time in various studies, it seems that they're unnecessary, where a person is more likely to have had a viral infection or no infection at all. And when you look at hospitals with similar patient populations, prescribers in some hospitals might prescribe as many as 3 times as many antibiotics as those in some other hospitals. So I think we still have a lot of work to do in being as judicious as possible with our antibiotic prescribing. And it's also important to mention that antibiotics are the most common reason that children present to emergency departments for adverse drug events. So this is Adina Avdich. She's one of the infectious diseases pharmacists in our hospital. So we had worked in a project to try to quantify the harm associated with antibiotics. We had looked at about slightly less than 1,500 patients who were admitted to the general wards at Hopkins, receiving at least 24 hours of oral or intravenous antibiotics. And we separately used a structured criteria to decide if it was more likely than not, if there was an adverse event, was it related to at least one of the antibiotics the patient was receiving. And we had some predefined definitions for various sort of organ type toxicities. We found that about 20% of the cohort developed antibiotic associated adverse events, and about 20% of the patients who developed an adverse event really had no indication for antibiotics. So it wasn't that it was too long or maybe not the best agent, but really that there was no reason they needed antibiotics. And I think importantly, about a quarter of these occurred after the patients left the hospital. And I think that's particularly important for those of us who work in the inpatient setting, where often we don't realize what happens to the patient after they leave. If they're going to another emergency department with serum sickness, they develop C. diff and are hospitalized elsewhere, et cetera. We tried to quantify what the actual harm was. Sometimes it was additional hospitalizations. It might be a prolonged hospital stay, additional outpatient visits. And then, of course, the majority were really additional laboratory tests, EKGs, imaging studies, which I think as clinicians might not seem that detrimental, but certainly from the patient perspective, does cause some inconvenience and possibly some harm. So this is Sarah Cosgrove. She's an adult infectious diseases at Johns Hopkins, and she was my mentor throughout my fellowship and afterwards. And we wanted to take what we were developing locally at Hopkins in the pediatric and adult world to try to expand this as more of a national program. So through funding from the HRQ, we established something called the HRQ Safety Program. And the goal of this was to identify hospitals that had no stewardship program, to help those places identify a physician and a pharmacist lead, and to train them to be antibiotic stewards, as well as to actually work directly with the frontline clinicians across the healthcare spectrum. So we did this over 3 years, separately acute care, separately nursing homes, and we're currently doing ambulatory practices, which include urgent cares. And it's been very nice because in the hospital setting, as an example, each hospital established a stewardship program. They picked a unit, and we worked quite closely with the nurses, the NPs, the PAs, physicians, pharmacists, et cetera. So really everyone involved in the clinical team to help improve antibiotic prescribing. And this was how the program was structured. Several of the webinars had to deal with developing and improving the stewardship program. And these were, of course, targeting the physician pharmacist identified to lead the program. We also had a series of webinars that focused on developing a culture of safety around prescribing, because I think a lot of times someone might prescribe an antibiotic. If, for example, another hospitalist comes on the next day, they might wonder, well, I don't know why vancomycin was started, but I guess it was started. I need to wait till cultures are back. So just to help with those conversations, so this involved a lot of role playing of how to communicate with family members and other healthcare providers in being as judicious as possible with antibiotic use. And then the majority of the work focused on best practices in the diagnosis and treatment of infectious syndromes. This included content both for pediatrics and for adults. So these were the topics included. And for all of them, we used something called the 4 moments of antibiotic decision-making structure that we established for this program. And basically it asks 4 questions. 1, does my patient have an infection that requires antibiotics? So this encourages the prescriber to just sort of stop and think about, well, is it more likely than not my patient has a bacterial infection, or perhaps is this patient so ill that I can't really make that decision right now, but it's something I'll have to reassess later. The second moment has 2 questions, 1 to deal with appropriate cultures, the second with appropriate empiric therapy. So for example, do I need MRSA coverage? Do I need pseudomonal coverage? If the patient has a known allergy, what's an appropriate empiric therapy option in that setting? The third question involves 3 questions. After a few more, the third moment, involves 3 questions after some more clinical and microbiologic data are available, such as, can I stop antibiotics? Can I narrow therapy? Can I change from intravenous to oral? And the fourth focuses on the duration of therapy. So for each of these webinars, we walk the participants through each of these moments specific to that infection. There were 405 hospitals that participated in the acute care portion of the program. You could see here that it was really a pretty thin slice that were academic medical centers, and the majority were smaller hospitals. They often didn't have an electronic medical record system, so you might consider them under-resourced, often rural hospitals. And you could see that overall antibiotic use decreased. And looking at various subgroups, there was a trend towards some perhaps decreased antibiotic use. But I think our primary purpose was really not this outcome of antibiotic use, but more to equip people to feel comfortable making decisions around antibiotics, especially because so much of the evidence, the availability of drugs, resistance, et cetera, has changed so much since many of us have been in training. And we also actually found that hospital onset C. diff in these infections overall had decreased during this 1-year period. All the content from the program is publicly available at the link here, and we'll be soon populating with the information relevant to nursing homes, and after that with the ambulatory cohort, because separate material was developed for each of these 3 settings. So I'll switch gears a little and change from change from antibiotic stewardship to improved diagnostics. So as I was, I'm sorry, it seems like my screen, oh, there we go, okay. As I had mentioned earlier on, this child I had discussed at the beginning has what we call a carbapenem-resistant Enterobacterales. And for those of you who are confused, some say Enterobacteriaceae, some say Enterobacterales. The Enterobacterales order is now considered sort of more inclusive for what used to be called Enterobacteriaceae. So this is sort of the term that's evolved to include most of the gram-negatives that you know of that are not organisms like Pseudomonas or Acinetobacter. So, just very briefly on carbapenem resistance. So you could, if you recall, our child had a carbapenem-resistant Klebsiella pneumonia. There are different ways that bacteria become resistant to carbapenems. So one is the production of enzymes called carbapenemases. So what these do is they're produced by the bacteria and they cleave the beta-lactam ring of carbapenem antibiotics. So antibiotics like ertapenem, meropenem, imipenem, cilastatin. And for CRE, or carbapenem-resistant Enterobacterales, this is present in about 50% of the cases. So this explains why they're carbapenem-resistant. For organisms like Pseudomonas, this is very rare in the US, definitely less than 1%. And for organisms like carbapenem-resistant Acinetobacter, the production of carbapenemases is extremely common, probably more than 99% of them. Another mechanism is porin loss. So what this means is that carbapenem antibiotics are just blocked from entering the bacteria in the first place. This is very common in Pseudomonas and in Acinetobacter, which usually has multiple mechanisms of resistance, and present about half the time for the Enterobacterales. And a third major mechanism is the production of efflux pumps. So this means the antibiotic can enter the bacteria, but the bacteria has a mechanism to pump the antibiotic right back out. Again, this is very common in Pseudomonas. Really, I should say for all three, Pseudomonas, Acinetobacter, and Enterobacterales is commonly found. So you might be wondering, how much do we really need to know about carbapenemases? Is this relevant or not? And hopefully on the next few slides, I can convince you why it is. And just along this carbapenemase theme, so again, these are the enzymes that some bacteria make that make carbapenems inactive. There's three main ones. One is called the KPC or Klebsiella pneumonia carbapenemase. One is called the NDM or the New Delhi metallobeta-lactamase. And one is called the OXA48-like carbapenemase. So these are all found, can be produced by the Enterobacterales. So we know that, if you recall, with the CRE, about half the time they're resistant to carbapenems because of the production of carbapenemases. The other half, it's a mix of other enzymes like ESBLs, as well as a porin mutation or the production of efflux pumps. We do know that when patients have a CRE that's resistant because of a carbapenemase, their odds of dying is a lot higher than if it's because of a mechanism that's not related to a carbapenemase. We also know that these carbapenemase genes are found on plasmids most of the time, and these plasmids can easily spread between patients in the healthcare setting, as well as between patients and the environment and healthcare workers, and so can really make their way around hospitals and have been implicated in a number of outbreaks. And the third, which I think is very relevant to all of us, is that it really does impact our treatment decisions, which I'll show you in a couple of slides. So just as a brief overview of this, the KPCs that I mentioned have been found in all states in the United States. I will say that a lot of hospitals do not screen for these. It's not publicly reported on any sort of routine basis. So this is definitely, what numbers we think we have is definitely an underestimation, but they have made their way across the United States. They were actually first identified in a Klebsiella pneumonia strain in North Carolina in 1996. It probably seems like a long time ago, but it really isn't. And by 1997, I think what was amazing was they found their way into New York City hospitals, and less than a decade later, almost 40% of all Klebsiella pneumonia clinical isolates were producing KPC. So this is any Kleb pneumo, not just the carbapenem-resistant ones. And since then, they've spread across the United States. And we know that the Kleb pneumo that carry these enzymes, their specific bacterial sequence type is very much related to those from countries all over the world. These genes are no longer specific just to the Klebsiella pneumonias anymore. They can be found in any of the Enterobacterales, and they can actually occasionally be found in some of the glucose non-fermenting organisms, including Acinetobacter and Pseudomonas. The NDM, or the New Delhi metallobeta-lactamases, are also found in many states, as seen here by the darker green. Again, I think that this is definitely an underestimation because most places do not routinely look for this. They were first identified in 2006 in a Swedish national who had recently received medical care in India. And if you recall from our child at the beginning of this presentation, this is the resistance mechanism that was found with his Klebsiella pneumonia. And I think what's really scary in some parts of the world, like in India, these genes have made their way into community-associated organisms like E. coli or Salmonella. So you can have people who've never been exposed to antibiotics, never been in a hospital, have common infections like UTIs from organisms with these resistance mechanisms. And finally, the OXA48-like were first identified in Turkey. They're actually very common in some parts of the world, including Europe, where they're often the most common type of carbapenemase found. So this slide hopefully shows you why understanding not only if is something carbapenemase producing, but what the specific gene is, why that could be of importance. So on the left here, I have FDA-approved beta-lactam antibiotics in recent years. They include cefiderocol, which was FDA-approved at the end of last year, ceftazidime avibactam, ceftolozane tazobactam, imipenem cilastatin, so the same imipenem you might have heard of, that has a new beta-lactamase inhibitor called relibactam, and something called meropenem vaborbactam. So I know that these are all a mouthful. You know, unfortunately, in years to come, I think we'll be using a lot more of these drugs as we see more and more resistance. But what you see here is the KPCs, the NDMs, the OXA48-likes I just spoke about. You could see that there's varying activity between these agents against these organisms. And, you know, we can't actually target our treatment knowing something is just a CRE. It's particularly helpful to know actually down to the gene level what type of carbapenemase gene may be present. And there are some commercially available ways to do this. There are a variety of tests that are used on blood cultures that more and more hospitals are using. We use something called GenMark. A lot of hospitals might use a BioFire assay, and others use something called the Varigene gram-negative panel. So I do think that in the future, my prediction would be in the next 5 years, all hospitals will probably implement one of these, or if there may be others that are developed also, to know to the gene level what type of carbapenem resistance mechanism is happening. But I think what's particularly concerning when you look at the carbapenem resistant Pseudomonas, which, you know, certainly I'm sure is common with you for our cystic fibrosis patients and just some children who've been in the hospital for a long time, really, are at risk for, as well as carbapenem resistant Acinetobacter, which seems to be just for whatever reason much less of a problem in children than in adults, and Stenotrophomonas, which I just sort of threw on there because there's often limited treatment options. But you could see here that for some of these non-fermenters, like the Pseudomonas Acinetobacter steno, we really are in trouble in terms of what drugs we have available. So I just wanted to very briefly talk about cefiderocol, the antibiotic on top, both because it's the newest drug on the market, as well as, at least in antibiotics, as well as because it's different from all the beta-lactams we've had before that have been used in clinical practice. So just as a quick background, our innate immune system minimizes available free iron in response to bacterial infection. So when there's a bacterial infection, our body wants to hold on to as much iron as possible. And most of our iron is bound to hemoglobin, myoglobin, or the iron binding proteins like transferrin or ferritin. And what bacteria do to combat this is they upregulate the production of siderophores. And these are high affinity iron chelating compounds that scavenge for free iron. So cefiderocol is very tricky. It's a siderophore. So what it does is it uses this Trojan horse-like approach to gain entry into bacteria. So it binds free iron and it binds to it, and then it kind of tags along with the iron in iron transport channels into the bacteria. Then it separates itself from the iron, binds to penicillin binding proteins, disrupts cell wall synthesis, and causes bacterial death. And what's really nice about this is if you recall when I showed you the picture of carbapenem resistance mechanisms with the porin mutations or efflux pumps or the metallobeta or the beta-lactamases that could be produced, like the various carbapenemases, it seems that these should not cause frank resistance to cefiderocol, which is exciting. And as you recall from the earlier slide, it seems that both for all types of CRE, regardless of the enzyme produced, as well as the non-fermenters, it's expected to have high activity. So this is obviously very exciting. So I think what was very shattering for many of us in the resistance world is that these are data that's presented to the FDA. And my understanding is it was accepted for publication, so should be out soon. But what you see here is the blue is the cefiderocol, orange is usual therapy. And what they used as usual therapy were things like extended infusion meropenem plus maybe an aminoglycoside or colistin. So there were drugs that we don't think of as sort of the best options currently available anymore. They weren't some of those newer drugs I had on the earlier slide. But what's really concerning, separately, they looked at pneumonia, bloodstream infections, UTIs. Again, blue represents cefiderocol, and you could see that the mortality, so looking at the left, the percent of patients who died, was higher, and it was actually significantly higher in the pneumonia subgroup. I don't believe it was significant in the bloodstream infections, but just visually, I think we all agree this is concerning. So, you know, unfortunately, we still need more work to figure out when and how we can use this drug. But it's just this reminder that we really are in kind of a dire situation when we start thinking about some really drug-resistant infections. You know, I'd argue that we've had quite a few drugs introduced to market in the last few years, which is great. But unfortunately, they don't have a broad enough spectrum to cover all the different problematic pathogens we're seeing in the hospital. And then, as Hayden mentioned, the Infectious Disease Society of America has very recently published guidance on the treatment of antimicrobial resistant gram-negative infections, and these focus on ESBLs, carbapenem-resistant Enterobacterialis, and what we call difficult to treat resistant Pseudomonas. And this means Pseudomonas resistant to Pip, Bacillin, Tazobactam, Cefepime, carbapenem. So pretty much all the beta-lactams and fluoroquinolones that we would normally consider as treatment options. So, you know, speaking of everything I just mentioned with treatment and thinking back about our patient at the beginning, you know, one of the ways we can try to at least get ahead of these is by improving detection of drug-resistant organisms. And if you recall from the patient at the beginning, it took several days because a lot of times, you know, you have your standard antibiotic panel, you see it's carbapenem resistant, and then you start adding on testing for some of the newer drugs or the drugs we think target more resistant bacteria. And then that takes a few more days to get those results back. So initially, Dr. Simner, who was featured on the earlier slide, who's one of our clinical microlaboratory directors, and I were very interested in looking into this. We started off looking at various phenotypic approaches, and one that we found to be highly accurate to determine if a CRE was carbapenemase producing or not is called the modified carbapenem inactivation method. So very briefly, what happens here is that you have you have a loop of bacteria placed in broth. You add a meropenem disc to that. Then you let it incubate for a few hours at room temperature. And then on a Mueller-Hinton agar plate, you inoculate it with a very susceptible E. coli. So an E. coli that pretty much all gram-negative agents should kill. And you put that meropenem disc on it. Now, if that bacteria was actually producing a carbapenemase, it would technically hydrolyze all the meropenem on that disc, and you're basically placing a totally inert disc on this plate. So then you let it sit for about a day, and then you read the plate. And where you see the black line that says no carbapenemase activity, basically what this means is that if that bacteria was not producing a carbapenemase, that meropenem would very easily kill the E. coli around it. So the E. coli would not be able to grow close to that disc. But where the red text is, if that bacteria was indeed producing a carbapenemase, now that meropenem disc is completely inactivated, right? Because it was already mixed with the bacteria and with the carbapenemases. And now even a very susceptible E. coli can grow up to the meropenem disc. So this method is pretty accurate, but the problem is it takes time. And you know, as with the patients discussed at the beginning, oftentimes patients infected with these types of organisms don't have a lot of time for us to do these types of tests. So more recently, what we've been working on is trying to improve the process with whole genome sequencing to look at both resistance genes like carbapenemase genes, ESBL genes. So these are common resistance genes in gram negatives, but also chromosomal mutations. And these might lead to resistance to things like aminoglycosides or colistin or fluoroquinolones. And certainly for the newer drugs, most of the resistance is related to chromosomal mutations. So, you know, our ultimate goal with this would be to try to make this accurate, relatively user-friendly for labs where some of it's automated. So in the future, again, I think this would be sort of more of a 5 to 10 year type of thing that laboratories could very easily, I put easily in quotations, but relatively easily look at a comprehensive list of mechanisms of resistance to know if an organism is likely to not be active against particular antibiotics. And just to sort of visualize this a little, in the green on the left here is what sort of traditionally happens. This is an example from what would happen in the Hopkins lab, where we have a positive blood culture. We use something called MALDI-TOF to identify the organism. So now we might know it's Pseudomonas aeruginosa. Then our microbiologists will test it against a standard panel. Once the organism grows sufficiently, they might see that it's carbapenem resistant. And at that point, people will ask, well, can we check ceftolozane tazobactam or cefiderocol or some of these new drugs? So there's quite a bit of delay that could happen. And on the right is sort of what what Trish and I are working on to see if we could do this earlier than with standard methods. As a sort of preliminary study, we looked specifically at 40 Klebsiella pneumonia isolates. Some were very drug resistant and some were much more susceptible. And what we found was that we could identify full resistance genes and mutation within about 14 hours from the time of the bacterial culture. And the agreement, when we looked blinded at the genetic results and tried to predict what the susceptibility testing results were, was about 91%. If we could do it at 8 hours, but it would only be 77%. So, you know, there's still a ways to go. This, you know, of course, looked at only a single organism. When you throw on Pseudomonas and Acinetobacter and all the different gram negatives, you know, it would significantly complicate things. So there's definitely more work to be done here. But it's possible that at some point during all of our careers, this would become somewhat of a standard in microbiology labs, some more automated version of this. And just to give you an example of one of the 40 patients in the cohort, it was a 64-year-old female who had a liver transplant. She was quite septic, so started on meropenem and vancomycin. Her blood cultures grew Klebsiella pneumonia. At 48 hours, her isolate was meropenem resistant. More drugs were added. On the right here is all sorts of resistance genes and mutations identified. And the green and red just basically shows susceptibility, which was able to be successfully predicted, susceptibility to various antibiotics, which was able to be predicted based on the resistance mechanisms identified. And this is an example of what her timeline was for antibiotics. And with the use of an approach like this, we could potentially get her on a more effective antibiotic earlier in her timeline. So the last thing I'll talk about is novel therapeutics. So some of you might have heard about this case. It received quite a bit of attention. On the bottom right here is Tom Patterson. Him and his wife, he lives in San Diego. He's a researcher there. And at some point, him and his wife decided to go to Egypt. They were both in pretty good health, but he became quite ill while he was there. And he was diagnosed with a pancreatic pseudocyst. It was eventually found that the pseudocyst was caused by a pan-drug-resistant Acinetobacter baumannii. He was eventually transferred back to San Diego, They were considering hospice care for him because he was doing so poorly. But his wife actually, who works with Chip Schooley, who's an infectious disease physician, the picture above them, she actually had been researching any other approaches for really drug-resistant pathogens, and she found that in some places, like in Georgia, like the country Georgia, in the former Soviet Union, that people were using bacteriophage therapy. So Chip applied for an emergency IND from the FDA to see if this could be an option for Mr. Patterson. And he actually gave him intraperitoneal bacteriophages, as well as, I believe, intravenous bacteriophages. And relatively quickly, he had a dramatic recovery and turned around quite quickly, which is pretty remarkable. Obviously, this is an N of 1. He still continued to receive antibiotics, although you could argue they were not active against his organism. And he did have some surgical procedures as well. But, you know, it's definitely promising that perhaps this is something that could be explored further. And just as a brief history on bacteriophages, they were separately identified by 2 independent investigators in the early 1900s. Frederick Twort, who was in Britain, and Felix Durel, who's a French-Canadian. But phages, you know, prior to the 1940s, they were commonly used to treat bacterial infections. Eli Lilly was manufacturing them. But as antibiotics became introduced in the 1940s, in the Western world, use of bacteriophages, research on bacteriophages really stopped. But it continued in the former Soviet Union, both research-wise as well as clinically. Unfortunately, there's very few published reports on the experiences from there to sort of glean, like, how should we be administering them and studying them further to see if they truly are effective or not. In recent years, because of our issues with drug resistance, there's been about 40 case reports describing the use of bacteriophages. There's probably more than this now. But, you know, I'll be honest, and it's very heterogeneous. Sometimes it's Acinetobacter, sometimes it's Pseudomonas, sometimes it's Staph aureus, all sorts of infections. These are, of course, being used on the sickest patients when nothing else is available. The doses of phages are different, the durations are different, and all of these patients are also receiving antibiotics. So it's really hard to know what is the additive effect of phage therapy. And just very briefly on how phage work, they encounter a bacterial cell. The phage binds to the target cell, it injects its DNA. The phage basically turns that bacteria into a bacteriophage factory. The cell bursts, new phages are released, and then it goes on to target new bacteria. And eventually, as the bacteria is eliminated, the phages have nothing to attach to, so they also get cleared. And from the reports we know so far, they seem to be quite safe. So there's all sorts of benefits with phages. They're the most abundant life form on Earth. They're particularly found in areas where there's a lot of sewage. They can treat antibiotic-resistant bacteria, so we don't have to worry about that. The resistance to a phage is very much unlinked to antibiotic resistance. And since we have sort of this endless supply of phages, it seems that phage resistance is less of a concern because there can always be some new phages that can be explored for a bacteria. It seems to actually they seem to work quite nicely to disrupt biofilms. They're pretty host specific, so that the collateral damage to the human cells seems minimal. And of course, you're able to possibly reduce exposure to antibiotics. My personal feeling is they'll probably always be used with antibiotics, so there'll probably still need to be some antibiotic exposure. But as I mentioned, we have a long ways to go into studying how to administer them, and honestly, if they're even effective, because it's still not entirely clear. So I'm working with Chip Schooley now on an RCT. This is a very early study. It's a phase 1 study. And the first patient is supposed to be enrolled, is expected to be enrolled in March 2021. But it's basically looking at the microbiologic activity and the safety of a single dose of an anti-pseudomonal bacteriophage cocktail. So it'll include 4 phages in 72 cystic fibrosis volunteers. So, you know, in my mind, this isn't the target population. I think bacteriophages, if they are indeed effective, with people with device infections like LVADs, prosthetic joints. So some of these sort of infections where there's biofilm, there's lots of issues with source control. I think that's probably the best place for these kinds of, for phages. But what we wanted to do was look at a population who had some sort of stable Pseudomonas colony count, so we could get a sense of when they're in good health, so obviously not when they're having a CF exacerbation, to get a sense of what a single dose of this phage cocktail would do on their Pseudomonas bacterial activity. So again, this is definitely a very early study in terms of all the data that will be needed before phages can be, if they indeed come to that point, if they can be considered for treating patients. But, you know, I think my guesses would be we would do the single dose. The probably next step would be multi-dose, and then starting to use it for actually treating active infections. Thank you all very much. I know this was a lot of material, but, you know, I hope I was able to convey to you that multi-drug resistant infections really continue to challenge clinicians. Unfortunately, well, fortunately, as medicine progresses, we still will have more patients with devices. We'll have more patients who have significant immunocompromise. But I think that drug-resistant infections will only continue to be an increasing problem for our patient population. And this is true for both children and adults. And I also think that to really combat it effectively, we need a multi-pronged approach that includes enhancing our stewardship practices, really with the goal of using antibiotics as effectively as possible. And I know Hayden would agree, our goal is not to restrict antibiotic use or be the quote antibiotic police, but it's really more, we want people to use them as wisely as possible so that they continue to be options for our patients in the future. Of course, infection control practices continue to need to be optimized, as well as improving diagnostics, treatments, including novel non-antibiotic focused therapeutics to really fight this problem. So I'll stop here, and I'm happy to take any questions. I'll turn my camera back on. Okay.
Great, thank you so much, Pranita. That was really fantastic. As a reminder to everybody, if you have questions for Dr. Tamma, you can put them into the Q&A. We do have a couple, Pranita. I'm going to go ahead and tell you what those look like, and then I'm going to actually expand on a couple of them as well. So one of the first questions was about the patient you initially started with and the superbug that they presented with. The question was whether this was like a sort of isolated event or something you're seeing more broadly in the Johns Hopkins community. And I think what I wanted to kind of build on that was differences that you're seeing between pediatric and adult populations with these kinds of multi-drug resistant gram-negative infections, and then specific risk factors that this patient or others might have that would clue you into this being a potential issue.
Yeah, no, thank you. Thanks for the question. So, you know, we, being a tertiary care hospital, as of course as Stanford, we do have, this is obviously pre-COVID, but a fair amount of our population coming from abroad. You know, it's actually interesting, about 20% of our inpatient pediatric beds were patients coming from the Middle East, South Asia, and various international sites where various carbapenemase producing organisms are a very large problem. So both in our pediatric and adult side, we've had quite a few carbapenem resistant organisms, including producing an enzyme like the NDM that I mentioned. But, you know, for this particular child, you know, he was totally healthy. It's just that he was diagnosed with leukemia. So what my guess happened is he had gone to India, as he did every summer, as a healthy host. He probably became colonized with the Klebsiella pneumonia there. But then when he came back and his immune system really took a hit, and he had central lines and all of that related to his chemotherapy, it allowed for this Klebsiella to cause an infection. But, you know, I think, as I had said earlier, I think Acinetobacter, for whatever reason, is the one organism in pediatrics. We just don't see a lot of carbapenem resistant Acinetobacter, even in babies in the NICU who've been there for months or children in the PICU who've been there for months. Unlike Pseudomonas, which I think we all agree, is certainly a problem in children.
And sort of building on that, Pranita, another question that sort of flicks at that is how prevalent CRE and other resistant gram-negative bacteria are in factory meat production, and sort of the intersection between agriculture, animal husbandry, that sort of thing, antibiotic use in that setting, and the impact that that has on multi-drug resistant infections in people.
Yeah, I mean, so there's some examples from parts of the world where there's less restrictions on antibiotic use. So as an example, in India and in China, polymyxins like colistin were used very commonly in animals, and very commonly polymyxin resistance was seen in patients. China had since sort of reduced that practice significantly and possibly even banned that practice, and the colistin susceptibilities improved quite quickly. I think there's definitely been for ESBLs a fair amount of work, so extended spectrum beta-lactamases. So those would be enzymes that cleave most beta-lactams, but not the carbapenems. There's been a fair amount of work in the US and other parts of the world that they are very much directly associated to the practice of giving animals prophylactic doses of antibiotics, so that because it's been shown to help them gain weight. But of course, a collateral problem is the development of resistance. And I can say I'm very on top of that literature, but there's definitely enough studies out there to show that one way, particularly with the ESBLs, that they occur in humans, is this association with consuming animal products. And even when there's things like chickens being transported, it kind of gets into the air and then gets into the soil. So yeah, it's a problem.
No, I know it's an area of a lot of work in stewardship more broadly, and in the antibiotic use in that population and in animals in agriculture. So I think more to come too, but thank you for that answer. This was a question I had too, Pranita, and I know like every time we have a super bad bug, which thankfully isn't too often, I shoot you an email and beg for advice. But one of the questions is whether we have any new antibiotics that include PD/PK data for pediatric patients. So let's take Cefiderocol, for example. Seems really promising, has very broad activity. Talk to us a little bit about the use of these more novel agents in pediatric patients.
Yeah, so one nice thing with the new drugs, just because the FDA realized we need to get a lot of these into the market quickly, and drug development takes time, the FDA process takes time. There's been initiatives in the last several years to allow for large phase 2. So if there's the in vitro data about these drugs are active against resistant organisms, phase 2 studies often go for sort of the quote easiest indications like UTIs or skin and soft, or they call them skin and skin structure infections, on very susceptible organisms compared to the usual beta-lactams we use like piperacillin and tazobactam. So that sort of accelerated the process of drug approval. But part of this also is that they're now required for these new drugs to also have a plan in place for phase 1 studies in children to proceed. So for Cefiderocol, I haven't seen the data on what they've been doing in children. It's certainly not, there's not dosing available in children. And there's not any kind of published phase 1 study. But the nice thing is for all the other antibiotics on that list, there are pediatric data available that include PK studies. So I do think we're in a good position in the sense of it might have to lag behind the adult data, but all of the companies that are making new drugs have plans for how to study them in children.
That's great, and thanks to all the pharmacists out there that help us when we're trying to figure out the dosing based on that limited data that's out there. There's a couple of questions left. One I think is a little more straightforward. There's a question about the use of bacteriophages when the mechanism of resistance is the inability of antibiotics to enter the bacteria, and whether that plays any role when you're considering the use of like a bacteriophage as a strategy for treatment.
Yeah, so, fortunately, it doesn't seem to be a problem. Bacteriophages are quite sneaky, and they can use a porin, they can use an efflux pump. there's all sorts of mechanisms they can use to get into the bacteria. So luckily it's very uncoupled with antibiotic resistance. And one thing that I think is interesting, one group had done some work where they had, I can't remember the organism, but some gram-negative organism, and the phages were actually using a tetracycline efflux pump to sneak into that bacteria. And the bacteria said, you know, hey, you don't belong here. I'm going to kind of get rid of this pump so you no longer can enter. But by getting rid of that pump, it actually became susceptible again to tetracyclines, because now they couldn't sort of, you know, pump the tetracycline antibiotics out. So it's actually kind of interesting how they might actually help us with some of these drug-resistant bacteria. And there's people definitely much smarter than me working on this who are looking at engineering phages for that purpose. So luckily, I think that the answer to that is that antibiotic resistance should not inhibit us from being able to progress with bacteriophages if they are shown to be effective.
Great. There's one more question. I'm going to save it for the end, and I'm going to actually ask a question that I was thinking about. I'm curious to hear your thoughts on the management of ESBL urinary tract infections in children, just because I would say that's probably the most common scenario that we're dealing with here. And it's a situation that I think intersects both outpatient and inpatient pediatric medicine, right? Like it's a pretty common story. You see a kid in clinic, you suspect a urinary tract infection, you start them on Keflex, cephalexin, the susceptibilities come back and it looks really nasty, but you call the family and they tell you actually kid is doing better. I want to sort of like work through with you your thoughts about that. I know Marie Wang, Alan Schroeder, others here at Stanford have started looking at this seeming bug-drug mismatch and what that all means when we're thinking about how to treat these kids. But as an expert, would love to hear your thoughts about this as well.
Yeah, no, thank you, Hayden. I definitely share your thoughts on that, because I agree. I think ESBLs are becoming more and more of a problem. I think it's something like the CDC in that 2019 report said something like between 2012, 2017, ESBLs increased like 53% in the US. They used probably a pretty generous definition, but regardless, they're definitely on the rise. They're definitely more and more common in the outpatient setting. So like, as you described, healthy children going to the ED. So with the UTI question, you know, in the adult world, they often categorize it as asymptomatic bacteria. So people who have bacteria in their urine, it's not causing any kind of harm. And there's actually been studies showing if you treat that, so if you just randomly get a urine culture, bacteria grows, but the patient's asymptomatic and you treat it, they're more at risk for a clinically significant infection in the future of UTI in the next 6 months. And that's also more likely to be drug resistant. And it seems that, you know, we've all been taught when we were in training that urine is sterile, but it seems like it's actually probably not. That for some people, having some bacteria there seems to be protective for some reason. So what we've decided to do in our hospital is categorize asymptomatic bacteria, cystitis, so that's sort of the lower tract, dysuria, burns when I pee, urgency, frequency, and then of course pyelonephritis when someone's febrile, hypotensive, having Rikers, etc. So for the sort of cystitis, the type you're describing, you know, I think one thing to keep in mind, as you very nicely said, is that when you actually look at the natural history studies of cystitis, without any antibiotics, about 1 in 40 progress to pyelo. So most of them, even without treatment, will get better. So I do think those scenarios where, just like you, cephalexin is kind of our go-to. If you started that, you find out it's an ESBL, what we would suggest to our clinicians is call the patient or the family, see how the patient's doing. If they're fine now, then that's fine, it's over. I wouldn't actually bother do anything differently. If it's a pyelo and they're actually sick, I would actually put them on something effective. But certainly if it's sort of a cystitis, I think it's fine. What our go-tos, I would say, for sort of ESBLs, 2 drugs that, if they're active, would be great are nitrofurantoin or trimethoprim sulfamethoxazole. Other options, if they're active, if these 2, I think, cause the quote least collateral damage, and in terms of adverse events are probably less concerning because you're talking about a 3 to 5 day course at most for these cystitis. But other options would be fluoroquinolone. So if it's cipro-susceptible, cipro will work. And then, of course, if nitrofurantoin is not an option, Bactrim's not, trimethoprim itself is not an option, the quinolones are not an option, you might be stuck with what we often would suggest is a single dose of an aminoglycoside. For cystitis, it's certainly been shown to be effective. We always forget about that, or at least I definitely forget about that. And then, if they're hospitalized, you might do something like a carbapenem. If for some reason none of the other options are tolerated or so forth. One quick thing I'll say is people often ask about the antibiotic fosfomycin. So fosfomycin's used a lot more in the adult world. It does have activity against, it's oral, and it's actually sort of dissolved in liquids, so dissolved in water, and you can drink it. In the adult world, they use this a lot more commonly for resistant bacterial infections. But unfortunately, most gram-negatives, including Pseudomonas, Klebsiella, have an intrinsic resistance gene called a FOSA gene, so it's not active. So really, the only gram-negative it's been sort of shown to be reliably active are E. coli. So if you have an E. coli cystitis, a single dose of fosfomycin, which is oral, is also an option. My understanding is it tends to be more expensive, so if you can do one of the others, it might be better for the family.
That's awesome. Thank you so much. And then Pranita, do you have 1 minute for another question? I know we're over time, but if you have a minute and the grand rounds people will indulge me, I think this is an interesting and, we'll see how you're able to answer this. The last question from the audience is, how can we align the incentives of clinicians and society to help with stewardship? Clinicians are heavily invested in short-term outcomes. They don't want the patient to die under their care. Compliance with the many metrics, evaluating time to antibiotic administration. This sounds like maybe an ICU physician. Patients in both their short and long-term outcomes, both immediate infection versus adverse effects, and then society in long-term outcomes, avoiding resistance. So a lot of competing incentives and priorities when we're thinking about those different segments of this equation, and your thoughts on that.
Yeah, and I mean, obviously, Hayden, you have so much experience doing this, so I'm sure you have strong thoughts one way or the other on this too. But, in my mind, I think when I had sort of started our stewardship program in 2012, and I think it was very much received as this restrictive program and nobody wanted to talk to us and all of that. I think now that people understand we want it to be much more educational, we'll work together, because I think what's important for all of us is to make the goal getting the patient better with the right antibiotics and minimizing the collateral damage to the patient. And, I'm very much somebody, if a patient is sick coming to the ICU, I'm very much about being aggressive up front with broad therapy, but peeling back as soon as we get information that helps. And, we have some really good RCTs, particularly in the adult world, on various types of pneumonia, bloodstream infections, intra-abdominal infections. There's no reason in my mind it can't translate to children. So I think, yes, I completely sympathize with the person who asked this, the anonymous attendee who asked this question about, we agree with our ICU colleagues and ED colleagues and everyone about being aggressive up front when needed, right, for a sick patient, for the immunocompromised patients, et cetera. But I think it's good for all of us because it really is protecting our patients when we get more information to kind of narrow therapy, switch to oral if it's possible, come up with an evidence-based duration, instead of sort of these prolonged treatment durations that we're often doing to treat ourselves and to feel like we're doing something when they're not benign and they're actually causing harm to the patient. I know that's kind of an obscure answer, but.
No, I think we share your philosophy. And I just really appreciate, Pranita, the opportunity for you to come and speak with us. Again, really sorry that you weren't able to come and visit us in person, the beautiful weather, the beautiful area, and the great hospital. But we really appreciate your time. And every time I hear from you, I feel like it's a crash course in the diagnosis and management of these really tricky infections. Eventually, it'll stick. And I'll remember everything you're trying to teach us, but thank you again, really appreciate it.
Thank you all very much. This was really nice, and yes, one day we will all be back in person again.
Thank you so much. Take care, Pranita. Bye-bye. Thanks, everybody.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.